board. All right, so lecture 19, we're moving on to compatibility testing. We've mentioned this several times throughout this, so now you guys are actually going to understand what compatibility testing is. And when you think about compatibility testing, it's important to think about the purpose of BloodBank. All right, so the role of BloodBank is to provide safe products for transfusion to replace what your patient is lacking. The key word there is safe, all right? Part of being a safe product is meaning that it is compatible with your recipient and that it will not cause any adverse reactions, okay? That's everything we do in BloodBank is to try to reduce the amount of adverse reactions that your recipient is going to have, all right? And so when you say cross-match or compatibility, you're thinking about how the recipient is going to receive that donor unit, right? And if it's compatible, that means your recipient antibodies will not attack the donor red cells, okay? So that would be a compatible unit, safe for transfusion. And so it's not just about compatibility. Also, if your patient has an unexpected allo antibody, we also must provide antigen negative blood, right? So not only does it need to be cross-match compatible, but it also needs to be antigen negative. All right, so think about the pre-cross-match. You guys have already talked about this. You want to do an ABO-RH and an IAT on your recipient, right? You want to make sure that there's no ABO discrepancies. You want to find out if that patient is RH negative, D positive, or RH negative. And then we also want to find out if there's any unexpected allo antibodies, all right? And so if you do have a positive IAT, you want to follow through with performing that panel and identifying that antibody. So everything that we have been building up to this point is to find antigen negative if needed, cross-match compatible units for transfusion for your recipients, for your patient, okay? So typically what's gonna happen in BloodBank, you're gonna get a request for a type and screen, all right? That's your ABO-RH and your IAT. And then they might order 2 units of packed red cells. They might even order 4 packs of red cells if your patient's scheduled for surgery the next day or anything like that, all right? So usually you have to have the order and the patient specimen. And you guys, I think we've talked about the requirements for the patient specimen. BloodBank is very particular about the patient specimen. You wanna make sure that the requisition and the specimen match, and you wanna make sure the phlebotomist initialed or signed the tube itself, all right? BloodBank used to even be more specific, and we're going to talk about a type and X armband. So if a patient was drawn for a blood bank sample, a special blood bank armband was put on that patient. A lot of institutions are now getting away with that, with the introduction of patient identification barcodes and everything like that. They're getting away from that type and X special armband, but I'll show you what it looks like just in case. And then historical records. In BloodBank, we will always look for history check on our patient. Do we already have a type on file? Does this patient have any previous antibodies? Has he been transfused within the last 3 days, 3 months? All right. Your patient's request form must have a minimum first and last name of your patient, an identification number, and the ordering physician, okay? Additional information that is very helpful for you when you're doing your history check and your testing. What's the age of your patient? Is it male or female? What's their ethnicity? What's their diagnosis? Where are they located in your hospital? Sometimes specific floors are associated with specific conditions, such as maybe it's the orthopedic floor. So maybe they're scheduled for orthopedic surgery, or maybe they're on the vascular floor. Maybe they're in OBGYN. Okay, that will help you know what's going on with your patient. The location can be very helpful. And then your transfusion, were they recently transfused? And if it's females, how many pregnancies has she had? Okay. Like I mentioned, blood bankers are very specific. And so we do not accept any incomplete or illegible request, and that includes your specimen. So this happened to me, and if your tech in charge in blood bank It is your responsibility to stand up and say, no, I'm not accepting that specimen. You need to redraw it, all right? So if they send down a tube and it's not labeled appropriately or it doesn't match the requisition, so let's say the requisition is on one patient, but your specimen is labeled something different, I don't know what happened there. I'm not accepting that specimen, right? I take no risk at all, okay? So I say you need to redraw it, right? The nurses will get mad at you, I promise, they will. But I'm like, this could potentially be fatal if I type this patient as wrong and then transfuse them the wrong type, right? So it's very important, all right? So you have that ability. You have to be able to stand up, all right? That's my soapbox.
You're something pretty anti-nurse this lecture.
I am not anti-nurse. I have mad respect for nursing. I am a big advocate for communication, and but I have had experiences where nurses call and ask questions, and I have had experiences where nurses argue with you. So it will happen, but just try to, remain professional and explain to them, according to my SOP, I cannot accept this sample. I am going to have you redraw it. So that's all you can do. They'll get mad at you and say, this patient's a very hard stick. I've already stuck him 3 times. And I'm like, I'm sorry. You should have followed protocol.
The next time you work that hard to get a sample, you'll label it.
Right. Like, I don't know, did you send the right requisition or the right patient sample? I'm not taking that risk. It's not worth it. And then they'll be like, well, can I come down? I had this happen. I kid you not. Can I come down and relabel the sample? No. All right, and then so on their request, it must state exactly what product is required and the estimated date of transfusion. So that estimated date of transfusion will be very important in just a minute when I give you another piece of information. All right, so some example products. Are they wanting to transfuse red cells? Are they wanting to do platelets, cryo, FFP, and then the exact date that they plan? Maybe your patient's scheduled for surgery tomorrow. So they're wanting 2 units of packed red cells on hold for surgery scheduled on February 25th. All right. So typically we want a written order. We like a paper trail in BloodBank. However, now it's if you have electronic medical records, it's all electronic now too. But a verbal and phone order is acceptable, but must be followed up with an official order, whether it be a paper request or in the patient's chart. All right. A verbal order would be like if your patient's in the OR and they're saying, I need 2 units of packed red cells on this patient, like right now. I don't have time to go in the computer and log it in. I need it right now. Okay. All right, so your patient must be correctly identified. So that patient sample and patient request must match, and all of your patient information must match what's in your computer system as well. You'll see this a lot with females. And here at UAMS, we would have patients that were born here 20 years ago, and now they're here maybe delivering a baby. And so they're still in UAMS system as Baby Smith, but on BloodBank system name, all right? So during admission process, UAMS updated their information, but remember at UAMS, our BloodBank system and the EMR does not communicate, right? So in that instance, we have to go into their file, look at their driver's license, look at their date of birth, and we have to prove that it is the same patient, okay? Or if your female has had a marriage or divorce and has changed her name. So if she had a established history at your facility and then she got married and her name changed, you have to verify that name change, right? Patient identification is very important. And like I mentioned earlier, your ID must be confirmed by the name band on the patient, right? So if you're involved in the phlebotomy process and you're collecting a blood bank sample, then you, really anytime you're doing the phlebotomy process, you want to confirm the identification on the armband. And if your patient is conscious, you can even ask them, what's your name and date of birth? And then that confirms your identity as well. Do not use the ID band if it's on the bed or if it's on the patient label on the door, all right? That's not acceptable. Typically, if you're in that situation, definitely contact the nursing staff and say that your patient needs to be appropriately identified. right, so here's your special armband that I mentioned earlier. It used to be termed the Type X or BloodBank armband. However, a lot of facilities are getting away from this, so don't be surprised if you don't see this. So anytime a blood bank sample was collected, they would do this Type X, and this is what it looks like. It has this long tail of numbers, usually a series of letters and numbers. And this was really useful if your patient was unknown, right? So then we could identify the patient by the series of numbers and letters. So they have their hospital armband, and then this would be addition anytime a blood bank sample was drawn. So this patient, this arm goes around your patient's wrist or ankle. Their information is on there. It's carbon copy. So this top part you could peel off and put it on your blood bank sample. This part remains on your patient, and they had to match. Right? So whatever was on your blood bank armband had to be exact what your patient information was. Okay, it was just another way to verify patient identification. And then you could tear off these tags, and then all of these stickers came with the sample. So when we cross-matched units, we could peel off these stickers and attach it to the unit. So the nurses that were transfusing could also use the blood bank sample for patient identification when transfusing. Okay. Like I said, you guys probably might not see this anymore because most facilities are getting away from it. Right? But if you ever hear Type X armband, this is what it's referring to. Blood bank armband, this is what it's referring to. UAMS no longer uses these, so you definitely won't see these at UAMS. And it's just because now your patient's armbands are all barcoded. So usually all the phlebotomists, before they do their phlebotomy procedure, they have to scan the patient's armband to verify patient identification. Okay, so in blood bank, we will do our testing on blood bank, and that includes ABO-RH, the IAT, and cross-matching units. That must be performed every 3 days, every 72 hours. So if you have a patient that's an inpatient and is in the hospital for an extended period of time and receiving transfusions, he has to have a new sample collected every 3 days. Okay, and that's just because we want to maintain an adequate immunologic state of him. Think about his hospital stay, and if he's receiving transfusions, we want to make sure if he is building antibodies from those transfusions. So that is why every 3 days a new blood bank sample has to be collected. Okay. Serum or EDTA, most blood banks across the board now are just using EDTA. There was a concern about complement. Using EDTA, the EDTA chelates the calcium, so it prevents the detection of complement, all right? Some people, if you're trying to identify if the patient is actively having complement, then you want to use a serum tube, all right? But in blood bank, we widely use EDTA. That's the most common accepted sample. If you guys remember, we talked about the kid family, especially kid A. He is known, he's an IgG antibody, but he is known to be able to activate complement, all right? Hemolysis, I've actually mentioned this to you guys before. If you receive a sample in blood bank and you spin it down and you notice that it is hemolyzed, that is grounds for request for redraw, because hemolysis is indicated as a positive result in blood bank. It already indicates that cell lysis has occurred. Was that due to complement? Is it due to an antigen antibody complex already? All right, so hemolysis is considered a positive result. Now, is that hemolysis due to a traumatic draw? Or is it a true representation of what's going on inside the patient? So that's why we will request a redraw if it's a hemolyzed sample. Specimen ID, again, must contain patient name, identification number, date, and the phlebotomist ID. I can't stress how many times that you will receive a sample and the phlebotomist did not sign it, all right? They have to initial and date it, put their full signature on there somewhere, right? Patient identification, very important in blood bank. Right, so what happens if that information on your specimen does not match the requisition? It must be resolved. The name changes I mentioned, if it's a female, You must log into her electronic medical record and prove that she had a name change. Maybe this happens too if your patient was admitted under an unknown, so they came in as a trauma. Once that patient ID is known, the medical records are going to be updated with that patient's true information. So then BloodBank has to update their system as well, right? So you want to make sure that you have patient driver's license or something to confirm that ID. Storage of samples. So once we receive the specimen in BloodBank, we perform our testing. We are going to keep that sample for 7 days, okay? And that is just because if that patient is transfused, we will keep that sample for 7 days to make sure that in the event of a transfusion reaction, we have access to that sample. We can repeat our testing and check for clerical errors. Part of the daily function of BloodBank is usually at the end of the day, like at 11:59 p.m., the specimens from 7 days prior are discarded, okay? So we kind of rotate all the tubes. And then a new sample must be collected every 3 days. That's a really good test question, all right? Every 3 days. And like I mentioned, history check in BloodBank is also very important. And so you must document this review. So here at UAMS, we had our requisition, we had our patient sample. There was a place where we would initial next to our history check to ensure. And if the patient had history, we would write that history down. Okay, so this patient is previously O positive with a negative IAT. Or maybe this patient is O positive with a positive IAT, anti-big E. All right, so we know what to expect in our testing. Or maybe, maybe 2 weeks ago, this patient was here and he had a typing discrepancy. Maybe he has anti-M that's reacting that initial spin, causing a forward and reverse typing discrepancy. All right, that's the kind of history that you look for. Helps you know what to expect in your testing. You also use that history check to confirm your current testing, all right? So if you have a facility that does bone marrow transplants and you have a previous patient that is typed as O positive, but has received a positive bone marrow, so now their type is changing to A. Why? Why are you getting a different type, all right? Number one, I'm gonna request a redraw to make sure. And then number two, I'm gonna try to find a proof of a bone marrow transplant, all right? That would, explain his type change. Okay. If you do have any discrepancies, so let's say you're testing O patient previously, but now you're getting an A, right? Number one, check your patient ID, check the sample, check the requisition, make sure what you looked up in your history was right. Request a redraw. I cannot stress this enough in BloodBank. Do not feel hesitant to request a redraw. All right, you can always request a redraw. Repeat your testing. All right, make sure you're using the right red cells, the right plasma. Make sure you didn't mix up from different patients if you have multiple patients in your rack. And if your patient has an antibody, you must confirm that antibody, and we want to give antigen negative units. For your donor blood, your collection facility is going to perform the ABO-RH in your antibody screen and the infectious disease, just like we've already mentioned. Once that unit is received at the hospital where it's going to be transfused, you must reconfirm that ABO-RH, all right? If your donor facility has already typed the week D donor as week D, all right, so they've already labeled it as RH positive. When you do your RH confirmation and you do initial spin, you're going to get RH negative, okay? So you'll have to confirm that with the donor center, but you do not have to repeat that week D test, okay? You guys don't be surprised if you start working in a lab or at your clinical internships that they do not do week D testing on the majority of their patients. They just do the D testing at initial span, positive or negative. They don't follow through with the week D. And the reason behind that is, except for moms and babies, okay, they will do that on moms and babies. The reason for that is because of our sensitivity of our reagents now, we are able to detect more of the D antigen, all right? And especially if you are doing ABO-RH typing using the gel method, the gel method is more sensitive than 2, all right? So if you're doing ABO-RH testing by gel, it will pick up more of the weak Ds, all right? And then your antibody testing must be performed at 37 and AHG. A lot of facilities now, don't be surprised, they're not doing initial spin testing. And why is that? What type of antibodies react at initial spin? IgM, really, they're considered nuisance in blood bank. All right, so a lot of clinical hospitals are only identifying those that are reacting at 37 and AHG, because that's what's going to react inside the patient. And we already mentioned this, you must do antibody identification. You must be able to identify all of the antibodies that the FDA deems clinically significant, all right? Most places will use a 3-cell screen. There are those with 2-cell screens, but it's very important that we don't forget dosage in blood bank, all right? So a lot of places have gone to that 3-cell screen. And if you look, I have a picture coming up that I'll point out in just a little bit. If you guys have paid attention to the IATs that you've done so far, both screening cells 1 and 2 are D positive, all right? And then sometimes you might have a heterozygous cell for JKA and then a negative cell for JKA. So most facilities like to include that 3rd cell. Number 1, it's going to give them a D negative cell. And then number 2, it's also going to give them a JKA homozygous cell, all right? Because remember, if it's heterozygous, that reaction is going to be weaker. What if it's so weak that it's maybe not reacting in the heterozygous state? So we don't want to miss our KID antibodies. Remember, the KID antibodies are the ones that are notorious for causing the delayed transfusion reactions because that titer drops so low, okay? When you do your history check, and let's say you know your patient has a positive IAT, maybe 3 days ago or last week, and you know he has anti-E and you know you have to give him anti-E, you can actually perform all of your testing at the same time. You can do your IAT, you can go ahead and run that panel. You can also go ahead, if you have E negative units already on your shelf, you can perform your cross matches, and you can get all of that done in one testing cycle. All right, so all of that can be done. But the caveat to that is you have to have that history, like you have to know. Right? A lot of times you're doing the IAT for the first time, you're not going to know it's going to be positive, okay? And then again, those nuisance antibodies that react at initial span, considered not clinically significant. However, there are some disclaimers to that. Anti-M, remember, can be of IgG classification and can react at AHG phase of testing. So you always want to pay attention to what phase of reactivity you have, okay? So here's an example. Most places will want to have JKA homozygous. So here's a 2-cell screen. Notice that both screen cells 1 are D positive, so you don't have a D negative cell in your screen. And then both of these cells actually happen to be homozygous. So this is homozygous for JKA, and cell 2 is homozygous for JKB. Then if you look at your 3-cell screen, your screen cell 3 is D negative, and then that cell actually happens to be heterozygous. So you have a comparison in your screen, right? You have a heterozygous cell, and you also have a homozygous cell for JKA, right? So having 3 cells in your screen gives you a better picture of what's going on in your patient. And you still have to follow up with the 11-cell panel, You have to get that 95% confidence level of antibody identification, but this gives you a better picture and you're less likely to miss a weak reacting JKA. Okay? So if your IAT on your recipient, on your patient is negative, there's a 99% chance that your cross matches will be compatible. Okay, what's the situation where your IAT will be negative, but your cross match will be incompatible? If your patient has an antibody to a private antigen, okay, meaning that your screening cells were negative for the antigen, but your patient has an antibody to a private antigen that the donor is positive for, okay? Or what's another reason? Anybody remember there's another reason that could cause a incompatible cross match? It's not recipient related, it's not really. It also will cause a positive weak D test when you're positive DAT in your donor, right? So if your donor cells already have something coding them, and that could interfere with your cross match. If you mix donor positive DAT cells with patient plasma, and you get an incompatible cross match that's unexpected, it could be due to a positive DAT in the donor. That would be at your AHG phase of testing. Okay.
Wouldn't that show up on your auto control then?
No, because you're using donor cells. So remember, in your auto control, you're using patient cells. Does that make sense?
If we do an elution,
For the donors, no, we're not going to do an elution. We're not going to figure out what it is. If you identify that your donor has a positive DAT, that unit is not safe for transfusion. We're going to discard those cells. And Sarah has a question.
Would you try to treat the underlying DAT?
So this is in your donor. So the only thing we have is the unit. All right. So it's not in the recipient. So if you have a DAT that's positive in your recipient, we must investigate that, right? But this is in your donor unit. All we have is the red cells. Right? So Sarah asked, would you put that unit back in stock? No. If you identify a positive DAT in a donor, that unit is discarded. Yep. Okay, so when you think about cross-matching, you think about what type of ABO am I going to give my patient? Like I mentioned earlier, we try to give ABO specific. So if your patient is A positive, we will try to give them A positive. We can give them even A negative, okay? However, if the group specific is not available, then we will try to give that A positive person a O unit, okay? It's still compatible. I want you guys to understand the terminology between type specific and compatible, okay? Type specific means your patient's A negative, you're giving them A negative. Compatible means your patient's A negative, you're giving them O negative, okay? That's the difference between type specific and compatible. All right, so just to review, what are the acceptable donor types, okay? So if your patient is A, they can receive, and this is red cell, you can receive A or O, all right? O is your universal donor for red cells, okay? If your patient is B, they can receive B or O. If your patient is AB, AB is the universal recipient for red cells. They can receive A, B, O, or AB, okay? And then O, he can only receive O, okay? So don't ever try to give a group O patient type A red cells, okay? That will result in a transfusion reaction. You might kill your patient, okay? And then for RH, if your patient is RH, they can safely receive RH positive or RH negative, okay? If your patient is RH negative, B negative, they should probably only receive RH negative. There are some extenuating circumstances. If your patient's a male in a trauma situation using a lot of products, we will switch them over to Rh positive. Okay? Never, ever, ever, I can't say this enough, give a female within childbearing age, if she's Rh negative, never, ever give her Rh positive cells. All right? And then if your patient is weak D positive, they are classified as Rh positive. They can safely receive Rh positive donor units and Rh negative. Okay. For plasma, so plasma is the opposite. Think about what's on your red cells. That's where your antigens are. Okay. Plasma is where your antibodies are. So it's the opposite of compatibility testing with plasma. Okay, so a type A patient can receive A plasma or AB plasma. AB plasma, think about what's on red cells of an AB patient. They have the A antigen and the B antigen, right? So in their plasma, they lack both the A and the B antigen. That is why AB plasma is the universal donor for plasma. Okay, so a B for plasma can receive B or AB. An AB patient, however, AB patients have both the A antigen and the B antigen on their red cells. They can only receive AB plasma, all right? And then type O, they have neither the A or the B antigens on their red cells, so they are the universal recipient for plasma. They can receive O, A, B, and AB, okay? Does that make sense to everybody? So I want you guys to be comfortable with plasma. You have to think about it backwards, all right? And notice that Rh is not a factor for plasma. Why is Rh not a factor for plasma? So your Rh, your D antigen is on the red cells, okay? There's no Rh to worry about in plasma, all right? So you could give A positive, or let's say you could give an A negative patient A positive or O negative plasma, it does not matter. As long as it's A, right? Or O, or sorry, AB plasma. Okay, so the cross-match procedure, what do we actually do? Number one, you're going to do your type and screen, your ABO and RH is performed that you guys are all used to. If your IAT is positive, you must follow through a panel. And I do want to say, I want you guys to understand when you fill out those antigrams, you do not have to fill that out on every patient. You only have to do the antigram if your IAT is positive, okay? If your patient IAT is negative, you report it as negative, that patient's good to go, all right? No problems. All right, we must perform cross matches on red cell transfusions, okay? The exception would be the emergency release that we talked about where the O negative units are given uncross-matched. So the cross-match kind of has a twofold purpose. Number one, it will make sure if your patient has any unexpected antibodies, it will make sure that the unit being transfused is compatible. Also, that cross-match is going to serve as an ABO confirmation. Do any of you guys know what's going to happen if you try to give a O patient an A unit? If you take O red cells mixed with, let's see, if you try to give a O patient, yeah, an A unit of red cells. At initial spin, yeah, at initial spin, you're going to have a 4+ reaction. Okay, so if you are ever doing cross-matching and you have a 4+ reaction at initial spin, that means that there's an ABO discrepancy somewhere. Okay. Why is that? So if you try to give an O patient an A unit. So in the cross-match, you're taking patient plasma mixed with donor red cells. What's in your O patient plasma? Anti-A and anti-B mixed with A red cells. What's going to happen? Your patient's anti-A is attacking those donor cells. It's going to give you a 4+ reaction at initial spin. Okay. All right, so just a little bit of the history. You guys remember that Landsteiner discovered the ABO system in 1900. It was actually not until about 7 years later, 1907, that the cross matches were discovered. And you have two different types of cross matches that we're going to talk about. One of these is no longer in use. And you have the major cross match and the minor. And it was not until the 1950s that we started doing antibody screening, right? And then about the late 1970s is when the minor cross match no longer became required. And I'm going to tell you what the minor cross match is. We do not do minor cross matches in blood bank anymore. And then the immediate spin cross match, this will detect our ABO compatibility, became prominent in the 1980s, and then the computer cross match became optional in the or available in the 1990s. There are a lot of restrictions on the computer cross matches that we're going to talk about. And when I say computer, you might also hear it referred to as electronic cross match. If you're, I'll tell you the restrictions in a little bit when we get there. You have to have a validated lab management system, blood bank management system in order to do an electronic cross match. Okay. Yes.
So I guess a lot of people died between 200 and 1950.
Yeah. Probably so. Well, and that's how things get discovered, right? So, like, what happened? 50 years. So.
Well, you're also talking about the time range for both world wars.
Yep. So a lot of blood bank discoveries happened during the world wars. All right, so your major cross match, what is still performed today in blood bank every day, you mix donor red cells, so the units that you're setting up on your patient, with patient plasma. You're making sure that when we transfuse those donor red cells into our patient, that your recipient is not going to attack those donor cells, okay? That's your major cross match. Again, it's also your final ABO check. And then if your patient has a positive IAT and you identify a clinically significant antibody, your cross match is essentially just an extension of your IAT. You're just mixing, you're changing what type of cells you're used, right? So in the IAT in your panel, you're using commercial manufactured cells, correct? In the cross match, you're still using patient plasma, but you're using donor cells for your antigen source. Okay, does that make sense to everybody? It's still just like your IAT. So you're going to have 3 phases of testing: initial spin, 37, and AHG. Right, now, when do you perform each phase of testing? That is dependent upon your patient findings. Okay, that's what we're going to talk about. And so we talked about this. If you're, oh, I guess we haven't talked about this. Okay, so let's talk about if your patient's IAT was positive, you identified an antibody, and then when you do your cross match is negative. Why would that cross match be negative, but your IAT is positive? What causes that IAT to be positive? Well, yes, but what causes the agglutination? What patient product are you using for testing in the IAT? Plasma. What's in the plasma? Antibody. So if that antibody does not react with donor cells, what does it probably mean about those donor cells? They don't have the antigen. All right. So if your patient has an antibody and your cross match is negative, that unit is more than likely antigen negative. Okay, does that make sense to everybody? However, we can't go on just a negative cross match. We have to phenotype that unit to make sure that it is antigen negative. And when I say phenotype, you have to have specific antisera mixed with those donor cells to see for agglutination. When you're phenotyping, if you have agglutination, that indicates the antigen is present. If you don't have agglutination, that means the antigen is lacking. Okay.
So is it possible that you have an IAT positive patient, but they don't react at all with the donor cells, and you can just send them on the way?
There are certain cases. So if you had a positive IAT, okay. So if you had a positive IAT and let's say it was Lewis A or Lewis B, those are known to be classification of IgM reacting antibodies. And so as long as you do your cross match and your cross match is negative, you do not have to phenotype. Those units are deemed safe for transfusion. because Lewis B is not linked to cause hemolytic disease of the newborn because it can't cross the placenta, and it's classified as an IgM antibody. Does that make sense? So that's one example. Anti-M is another one. So if your patient has IgM anti-M, and it's reacting at initial spin but warms away at 37 and AHG, and your unit is compatible, that one is deemed safe as well. But if it's reacting at AHG, then you must phenotype. So there's a lot of things you have to think about. There's a lot of circumstances. There's always exceptions in blood bank. All right, so speaking of exceptions, all right, so I mentioned 3 phases of testing in CrossMatch, right? Room temp or initial spin, 37 and AHG. Okay, so if your patient has a negative IAT and has no proven history of an identified antibody, you can just do an initial spin CrossMatch and be done, all right? Remember the reason for initial spin, it is a further ABO confirmation check, okay? So if you have an O patient, your unit is O, you do initial spin CrossMatch, it's negative, that unit is deemed safe for transfusion, okay? Your patient must have a negative IAT in order for that rule to follow, okay? If your patient has a IAT that is currently positive or has a known history of a previously identified antibody, you must do all 3 phases of the CrossMatch: initial spin, 37, and AHG. Okay? Does that make sense to everybody? The key word there is if your current IAT is positive or of known previous history. So what's going to happen if he had anti-E identified 5 years ago? Might not be reacting at this current time, right? But he had anti-E identified, so he does have anti-E. So if we were to give him E positive units, he's going to have a transfusion reaction, right? His anti-E titer is going to spike up and attack those donor units. Does that make sense to everybody? All right, so not only if maybe his anti-E is not currently reacting, we still have to give him antigen negative and then make sure that it's compatible at all 3 phases. All right, and just like we mentioned, you must give antigen negative donor cells if your patient has an antibody, even if it was identified 10 years ago. All right, so one thing in blood bank, if you guys don't know already, records are kept permanently in blood bank, okay? So some limitations to the major crossmatch, and again, major crossmatch is donor red cells mixed with patient plasma. The major crossmatch will not detect all unexpected antibodies, okay? So it's possible that your, let's see, maybe your patient had a positive IAT and your unit that you grabbed for crossmatch happens to be antigen negative, all right? So then you're going to get a negative reaction in your crossmatch, all right? So you won't pick up any unexpected alloantibodies there. All right, so think about your IAT and your panel. We know the antigenic profile of those cells, right? We don't know the antigenic profile of our donors. We're just confirming that those donors are compatible with our patient and they're not antigen positive for our patient's antibody, okay? The major crossmatch will also not prevent amnestic secondary, all right, responses, and it will not prevent like transfusion reactions that are due to allergic reactions. So that's the point of our crossmatches. We're trying to prevent patients from having a transfusion reaction. We're trying to pick the most suitable and safe units for transfusion, okay? However, we can't predict if a patient's gonna have a allergic reaction, if they're IgA deficient or anything like that. That has nothing to do with our crossmatch, okay? All right, so the minor crossmatch is the opposite of the major. This would be if you wanted to make sure that your plasma donor was compatible. All right, so you mix patient cells, okay, with donor plasma. That's That's your minor cross-match. This is not performed in blood bank anymore. Okay, there's no need to mix donor plasma with patient red cells. Okay, we will just give ABO compatible plasma to our patients. Okay. Another reason the minor cross-match is not performed, think about whole blood. If you are doing whole blood transfusions, whole blood has red cells and plasma, so we would need to make sure that that plasma is also compatible with our recipient. And because we typically do not do whole blood transfusions anymore, we don't have to do this minor cross-match. All right. You guys have chemistry today, right? Oh, you have molecular lab. Okay, so it is almost 12 o'clock. And so we will pick up here on Monday. Oh, I don't even know what day it is. I thought today was, okay, we will pick up here tomorrow. Sorry. I guess I was thinking today was Tuesday.
Actually, messed us up.
It's Monday and it feels like Monday.
I'm doing a poster presentation on Friday and I haven't even got my poster ready yet. Right? I need to get that thing submitted for printing today. So we are still meeting at 9 a.m. tomorrow. Okay, that should allow me plenty of time to get through all the lectures. Oh, do you have those results?